All right, hi everyone, welcome. Thank you all for making it, which sounds like some treacherous traffic. We're starting a little late, but we're gonna land this plane on time, I promise. Thank you all for being here. My name is Sandra Butler. I'm the director of the Springboard Studio, and on behalf of our entire team, welcome to our Design Impact Awards Demo Day. It's the culmination of a lot of hard work, which you'll hear about throughout the afternoon. First, a little bit about our Springboard Studio team. We believe that really practical innovation happens on the front lines in healthcare. Those who are facing the challenges every single day in our frontline providers, staff, and patients. They have really unique insights to change and improve how care is delivered. Our Springboard Studio team works with these providers using a design thinking process to really deconstruct and understand the challenges that they're facing and then support them in co-creating solutions. Our team's work has evolved over the past 15 years, really fostering innovations that make a real impact, both globally and here in the US. No worries. Fostering impact both globally and here in the US, starting by running hackathons, where we ran 27 hackathons across 3 continents. And then here at Mass General Brigham, establishing the I Solve Awards, the She Solves Awards, and the Design Impact Awards, which is what we're here to hear about today. The Design Impact Awards is a program that's open to all Mass General Brigham employees that have an idea to make healthcare more user-friendly. And that's really broad, and you'll see that reflected in the cohort today. The eligibility requirement for the Design Impact Awards is really around early stage innovators within our health system. And so we're really working with folks that are early in their career in innovation broadly. Today, you'll hear from 7 teams representing 6 Mass General Brigham institutions, all solving challenges that make healthcare more user-friendly. These providers and staff represent the best of our Mass General Brigham community, with reflecting diversity of roles, perspectives, and institutions, while united by a passion for creating meaningful change. Over the past year, each of these teams has received funding, $25,000 in a philanthropic award, as well as a year's worth of support from our Springboard Studio team, including some mentorship, design guidance, and really the space to think differently. They've engaged deeply with the people that are facing the challenges that they're tackling. They've iterated on their concepts and advanced their ideas. So to the teams here today, congratulations on making it to Demo Day, but not just making it here, really for your persistence, your curiosity, and your creative problem solving that got you here. All of you have full-time roles, and we know that. You have responsibilities and patience and demands on your time that don't pause, and yet you've chosen to go above and beyond to invest your time in solving these challenges, bringing your creativity and energy to make things better. And because of that, you've taken your ideas from insights into action. And that's really the only way that change happens. And that is what we're celebrating. Programs like the Design Impact Awards exist because of partners who are willing to invest early and believe in ideas before they are fully formed. And that is the power of catalytic philanthropy. So we are incredibly grateful for the generous support from the Massachusetts Life Sciences Center and Shepherd. Their commitment is not just financial, but visionary. They understand that relatively small but well-placed investments can unlock outsized impact, which is exactly what philanthropy does. So if anyone here has an interest or knows someone who might be interested in supporting future awards programs, please let us know, or can think of organizations that might be aligned in supporting these awards programs going forward. Please find me or any of our Springboard Studio team members today. Now, onto the structure of the event for the afternoon. After a wonderful keynote by Yvonne Howe, you'll have the opportunity to hear directly from these 7 teams to learn about the challenges they've tackled, the solutions they've developed, and the impact they're achieving. As I mentioned, these 7 teams are comprised of folks from 6 different Mass General institutions across Mass General Brigham. So in this cohort, we have Newton Wellesley Hospital, Wentworth Douglas Hospital, Mass Ioneer, Cooley Dickinson Hospital, Brigham and Women's Hospital, and Mass General Hospital. Thank you to all of the department leaders, supervisors, and colleagues across all of these sites who have supported these awardees to get their ideas to this far. A year of work and funding is a terrific start, and it's not enough to get an early stage idea to completion or sustainability quite yet. So we're asking all of you here today to listen for ways you might be able to help each of these teams as they begin their next chapter beyond this initial funding and support. I encourage everyone in the room to really listen closely, write down questions or thoughts you may have as teams are presenting, and think about how you might be able to support and amplify their work, whether it's mentorship from yourself or someone you know, an introduction you can make on their behalf. Funding is always a challenge. These are all ways that these teams are going to be looking for future help. So hopefully, as you checked in, you all received a playbill that includes today's agenda, as well as an overview of all of the teams that you'll be hearing from, as well as their contact information. So if you don't happen to meet someone today, you'll have their email address to be able to follow up with them. You'll notice on the opposite side of each team overview is a blank page, and that's where we encourage you to write down any thoughts, ideas, questions you have while you're listening to these presentations. We've purposely not included Q&A during the program, but instead have designed the reception so you could really easily find these teams at the end of the program, and we'll say more on that as we wrap up. Now, on to introducing our keynote, Yvonne Howe. There are two full circle moments that make Yvonne just the natural fit to keynote today's event, and I'm so glad you were able to join us. The first is a company called PillPack, which was founded by Elliot Cohen and TJ Parker with an idea to improve retail pharmacy and medication adherence. They fleshed out their idea at a hackathon our team co-hosted with MIT at Mass General Hospital. At the end of that weekend, they had won $1,000 with a cardboard prototype that said PillPack on it. And they have shared with our team that they never would have been a company without that event. Yvonne was involved in their journey on the other end, serving as COO and CFO, leading their sale to Amazon for nearly $1 billion. So $1,000 from us to $1 billion to Amazon. So quite an arc to that journey. The second full circle moment that makes Yvonne such a terrific keynote is actually happening right now. We're wrapping the second full circle moment, but it started while she was still with Governor Healey's administration. In her role as Secretary of Economic Development, Yvonne was chair of the board of Massachusetts Life Sciences Center, who is one of our philanthropic supporters, and was there when our grant submission was reviewed. And Yvonne's enthusiasm for supporting this awards program was relayed back to me. So I'm so glad you are here, and she is here to hear of all of the progress you have made and the impact of that decision to support an awards program like this. So on to Yvonne's formal yet abbreviated bio here. Yvonne Howe joined Flagship Pioneering in 2025 as Chief Operating Officer and General Partner. She leads core functional pillars that support Flagships and its ecosystem, and also supports company-wide strategic initiatives and works with Flagship's growth partners to help steward later stage companies. Yvonne most recently served as Secretary of the Executive Office of Economic Development for Massachusetts. She brings more than 25 years of experience as a senior executive, investor, and operator, including leadership roles at Cove Hill Partners, Pillar Ventures, Bain Capital, and PillPack, where she led the company's sale to Amazon. Earlier in her career, she held senior roles at Honeywell and McKinsey. Yvonne has served on multiple public and private company boards and is active in civic and educational leadership. Please join me in welcoming Yvonne Howe. Thank you for joining us.
Thank you so much, Sandra, for that very kind introduction. When Sandra emailed me about this, I told my Flagship team, whatever is going on, I'm going to be at MGB. So I couldn't miss this opportunity because I remembered how much I loved this program. And I'm so grateful for Sandra and her whole team and all of the work that you do to make Springboard happen. And I'm a huge fan of MGBs. I got to know Ann Klebanski really well in my role in state government and spent a lot of time with Chris Coburn and with Carla from Mass Life Sciences. We did a lot of great work together. So very grateful to be here today. And I think I really also needed this myself. We're living in such strange and sometimes very dark times, and it's very easy to kind of get overwhelmed or depressed. And I was like, you know what? If I come to this event, I think I'm going to get inspired. And already I am, because you walk in the door and you look at the boards, and how come the whole world doesn't look like that? I mean, raise your hand if you're one of the award winners. Like, yeah, woo! Women are half the population. I think they're like 80% of the workforce in healthcare, and yet they receive, I think, what is it, like 15% of venture dollars. We need the whole world to look like this. So thank you all for doing this amazing work, and congratulations on winning the awards. Sandra asked me to reflect a little bit on my journey and maybe some thoughts that might be relevant for the award winners and for all of us as we think about things. And the first thing, obviously, is PillPack. So PillPack was a crazy journey, and I think being in this startup is definitely not for the faint of heart. And it was interesting. I was working at Bain Capital. It's very fancy. We had a cafeteria. We were in the top of the Hancock Tower. You know, I was very lucky to be in that job. I learned a lot. I was doing great. And how did I get to PillPack? It's this funny story. So a friend of mine said, "Hey, Vaughn, there's a young guy who's in your neighborhood, and he's got this little startup. Can you go help him out? He needs some help." So I was like, okay, sure. As a favor to my friend, I'll go meet with this guy, TJ. So I'm walking over to the PillPack office to have coffee with TJ. And I'm like, what do they do again? And so I met TJ, and I realized, wait, you guys send prescriptions pre-sorted to patients' homes. Where have you been? Like, we had just, it's a really terrible thing, but we had just found out that my mother-in-law had Alzheimer's. And anyone who knows, that is the worst disease. And because we're Asian, we were like, well, we'll just have her live with us. And that was really, really hard. We had some really scary moments. And so we had moved her to a facility, but still every weekend we'd go to CVS, and we were trying all different types of medications to slow down the disease. And every Sunday we'd be sitting there after the kids were asleep, and we'd be looking at like the AM and the PM and the Monday and the Tuesday, and they all looked the same. And I was like, wait a minute, TJ, PillPack can send this to my house and I don't have to worry about this? And he's like, yeah. So I signed up my mother-in-law, and TJ kept in touch, and he was like, would you ever join us at PillPack? And I was like, no way. Like, why am I Bain Capital? Why have I never heard of you? You're like, a decade younger than me. Why would I join PillPack? I don't know anything about startups or healthcare. But then I'll never forget the day we got our first PillPack shipment, and we got the pack, and everything was pre-sorted, and it was a game changer for us. We had peace of mind that my mother-in-law could get her medications on time and accurately. And I was like, wait, this is a life-changing kind of experience, and healthcare is so broken in so many ways. So I kept talking to TJ. I ended up leaving Bain Capital, and I took a 90% pay cut to go to PillPack, and it was one of the best decisions I've made. It was so fun. But for the founders in the room here, you should know, and you already do, I mean, a couple of things. One is that it is not for the faint of heart. The highs are high and the lows are really low. And you have to kind of buckle up and be ready for the adventure. And the other thing I would say is that I think a lot of times you get really intimidated by, I thought the same thing. Wow, to be in a startup, you have to have some patents and IP and some super fancy, PhDs and acronyms and things. And we have a lot of that at Flagship, to be honest. So there is some of that in startup world. But honestly, the most important thing for being successful was being close to the customer. And at PillPack, I was a CFO and COO. So I did manage cash flow and metrics, and I was constantly looking at all the different, levers in the business. But every day when you walked in the building, in our operations center and in the office, in the headquarters, there were big posters with customer testimonials. And every day as CFO and COO, I would get the feedback of, hey, my mom used to be going to the emergency room all the time because she couldn't take her medications. Now she's living independently, and she's happy for the first time. Or, my kid used to not be able to go to summer camp because I couldn't, sort all the pills, and he could get confused. Now my son is actually able to go to summer camp and play with other kids, and I know the PillPack's going to work. The most amazing letter we got was I was in the office. I'll never forget. One of the receptionists came and said, we got a handwritten letter for you. What? Like, who writes a handwritten letter? And we get this handwritten letter, and it's this woman who wrote us saying that she's in her 50s. She'd been diagnosed with, severe mental issues in her 20s. And she'd never been able to, she's seen so many doctors, seen so many different, specialists, and never been able to get her life on track. And she was sitting at home, couldn't fall asleep late one night, and saw an ad for PillPack, decided to sign up, and got her medications on time and could take them. And she said for the first time in her life, she had hope. I mean, so the most important thing for founders and for all of you, which I love here, I was just talking to Christina and Yasa about this, when you're close to the customer and you're close to the mission, and you know why you're doing this business, why you're doing the hard work, why you're going to survive the high highs and the low lows, that's the most important thing to be successful. They were just telling me they're doing a pelvic floor startup because it takes 6 to 12 months to get an appointment. Like, that's a long time. And they have some very simple ideas of ways that you can start that work without, seeing the physical therapist. And so being close to the customer, being close to the mission, believing in what you're doing, that is the journey you're on. And one of the things that was helpful for us at PillPack is I found early on, especially if you're in a very big company, like Bain Capital is very professional, Mass General Brigham, very professional, you tend to like analyze a lot of things and you get super stressed out about every decision. And so one of the things we talked about, and then when we got bought by Amazon, they gave us a term for it, was different types of decisions and having the judgment around those. So at Amazon, they had this concept of which decisions are two-way doors and which decisions are one-way doors. And I think one of the challenging things is when you come from Mass General Brigham or Bain Capital, you analyze lots of things and you think every decision, we've got to like stress out about it. We've got to like, get all the data. We got to make sure. You think every decision is a one-way door. A one-way door means that it's a decision that once you make it, you go through, you're not going back. But actually in business, and especially in startups, almost all the decisions are two-way doors. When you're in a startup, you are just testing and trying and figuring out, does this work? Does this not work? You're talking to customers, getting feedback. And so having the judgment to know and letting go a little bit of the stress, and being able to say, okay, you know what, this is kind of a two-way door decision. Let's just go. If we think it's an idea, like, let's just try it and we'll get feedback and see if it works. Now, there are some one-way door decisions. Selling your company to Amazon is one, you're not going back after that. So there are some one-way door decisions that you have to really pay attention to, but a lot of it is, as a startup founder, just relaxing and figuring out how do we just get some two-way door momentum going and learn. So that's one set of thoughts I'll give. The other set of thoughts that I wanted to share was a little bit from my time in state government and from right now at Flagship. So in state government, I spent a lot of time talking to all of our businesses, and we worked on a plan, an economic development plan called Team Massachusetts, Leading Future Generations, and we passed an economic development bill, and we looked a lot at the state. And then now at Flagship, Flagship is interesting. So people are like, oh, it's so cool, you joined a venture capital firm. And actually, it's interesting, Flagship is not a venture capital firm. It's a really strange company, actually. We employ almost 600 people, and they're almost all scientists. And what we do is we let them work on big, crazy ideas. If it's a normal idea that someone else is working on, we say stop that project. We only let them work on ideas that are way far out, and we let them ask these big questions, and then we let them play an experiment, and we give them a little bit of money. And sometimes we kill a lot of things. Lots of things don't work, lots of two-way doors. And then some things work, and we give them a little more money and a little more money, and those things grow up to be companies. And so we've founded 120 companies. Probably the most famous is Moderna. And Moderna was started with a question 20 years ago that said, what if your body could make its own medicine? It's a crazy idea. And when they started asking this idea, they didn't even know about mRNA. So that was not even in the picture. But eventually they found mRNA, and then they discovered that actually you can program mRNA to create medicine, and that's how Moderna was born. But one of the things we talk about in state government, and then now at Flagship, I kind of now have the words for it, which is striking the right balance. So in state government, what I found a lot was people would walk around and be like, man, everything sucks. The weather sucks, which it kind of does right now. So, we'll forget the weather sucks, taxes suck, traffic actually did suck today. So that was true. So, traffic sucks. We don't have enough housing. Housing sucks. All these things suck. Okay. Those things are true. And you need to have paranoia, which we talk about at Flagship. As a startup founder, you have to be constantly paranoid. Well, how's the market changing? Who are the competitors? What do my customers need? You have to have paranoia. But you can't only have paranoia. Because if you only have paranoia, no one's going to invest in you. No one's going to want to stay in Massachusetts. No one's going to want to live here and grow their families and their companies here. So you also really need to have optimism. So at Flagship, we talk all the time because we are founders. We found companies. And when we have meetings with our scientists, we say we need paranoid optimism. So we need to know the paranoia. So what are you afraid of? What's not working? Let's be honest about it. We're not going to cover it up. But we have to believe. Where's the optimism? Where's the vision of the future? What are the strengths you're building on? And in Massachusetts, we're the envy of the world. Because guess what? We have Mass General Brigham. I mean, any state would kill to have this incredible institution in their state. We have Mass General Brigham. We have Sandra. We have all of you. We have these incredible ideas. And we do hard things. This is what we do. So we have to have a little bit more optimism. So the one thing I would say to the founders is when you're out there pitching and when you're working, I know you have paranoia because you're all close to the customer, and you see all the problems and all the things you want to improve, but have some optimism. Believe in yourself, believe in your idea, and be sure that you can sell the future, because we need that to get there. And recently I've been thinking a lot about the OG founders in our state, which is the amazing people on the battlefield of Lexington Green in 1775. And those are the OG founders, right? Because they founded the country. And I can't imagine you're a colonist or you're living here in 1775, and If they were only paranoid, they'd be like, oh man, we're outgunned. Oh wait, we're not really soldiers. Oh wait, we don't have cannons. Oh wait, and they never would have started a revolution. I'm sure all of those things were true, but guess what? They also had optimism, and they had courage to say, you know what? We think we can start a country. we're gonna start a revolution, and they won the revolution. And so let's channel that paranoid optimism from our OG founders and help us all be successful. And then the last thing I heard was I heard that there are some potential funders in the room or potential people who could invest. And I will say one of the things I think about all the time, and I spoke with the governor a lot about, and we think about a lot at Flagship, is this concept of ROI, return on investment. Now, there are many things that are screwed up in the world, and there's so many problems. There's many things that are hard for us to control. I don't think I'm going to be able to make a meaningful impact on the Strait of Hormuz and the war in Iran or the Middle East or Ukraine. But the one thing we can control is supporting these founders. It doesn't take a lot. It was not a huge sum of money. And if you can get that spark started, you can invest in one of these people who are super, close to the customers, who have ideas, who have solutions, and who believe in themselves. If we can give them a little bit of a spark, you get that kind of proof of concept going. You get the $1,000 in the cardboard box that was TJ and Elliott. Then we raised $115 million eventually, and we sold to Amazon for a lot of money, and everyone did really well. If we can get that spark going, they will collect outside investors, and they will go and change the world and help patients live better lives and help all of us be inspired and give all of us optimism and faith for the future. So congratulations to the awardees. We're so proud of you. I'm so inspired by you, and I'm so excited to hear all your ideas. And let's work together. Let's have paranoid optimism, and let's work together to build all of this. So thank you all so much. Congrats.
This is not the perfect keynote for this event. Yvonne, thank you so much. So many good nuggets in there, and I really like the 2-door, 1-door decision. I'm going to be bringing that back. All right, so how this will work today, I'm going to be emceeing, so you'll see me standing up introducing team by team, and we're going to start off with Drs. Lynn Fiore and Kristen Flint speaking to their work of increasing access to continuous glucose monitoring. There we go.
I'm Kristen Flint, and I'm an endocrinologist at the MGH Diabetes Clinic. I'm Lynn Fiore. I'm Lynn Fiore. I am a primary care doctor at MGH. We're so thrilled to be here today with all of you to present our project, Increasing Access to Continuous Glucose Monitoring in Primary Care. I am a diabetes doctor, and a few years ago, I realized that I was getting a number of referrals from primary care providers to start patients on continuous glucose monitoring. By the time these patients made it to see me as a specialist, they had been waiting for months just to start on a small piece of technology that could revolutionize their diabetes outcomes. What was this piece of technology? Continuous glucose monitoring. A continuous glucose monitor, or a CGM, is a small device that a patient wears on their skin that can measure the blood glucose every few minutes, every hour of the day, providing patients with comprehensive glycemic data without the need for finger sticks. And continuous glucose monitoring has excellent outcomes. Research has shown that it can improve overall diabetes control, it can reduce the incidence of life-threatening low glucose events, and it improves overall quality of life. So when I was seeing these patients, it occurred to me that we were doing them a disservice by making them wait months to see a specialist to start CGM. Around the same time, I met Lynn while we were both teaching in a Harvard Medical School course, and I pitched her my idea to build capacity at her primary care clinic so that her providers could prescribe and use CGM for patients with type 2 diabetes without the need for a specialist.
When Kristen approached me, this idea immediately made sense. I knew that as a primary care provider, I was managing diabetes a lot in the primary care setting. And this is true nationally, where primary care actually manages the most diabetes in the US and bills for that service more than any other specialty, including endocrinology. But I knew that I wasn't prescribing CGM, and neither were my colleagues. When I thought about trying to start prescribing, honestly, it was pretty daunting. We didn't have the clinical workflows to get it covered by insurance. My staff wasn't trained to use it or answer patient questions, and I didn't know what to do with the data. I'd never learned anything in residency about it. But Kristen and I decided this was a problem worth solving together, mostly because eligibility for CGM has been increasing rapidly over the past several years. Prior to 2023, CGM really was a specialty device that was reserved for patients with really severe diabetes, people injecting insulin multiple times a day. Those patients generally had endocrinologists, and so it was okay that CGM would live in the endocrinology space. That changed in 2023 when CGM started to be covered by insurers for people who injected insulin just one time a day. This made over 8 million Americans all of a sudden eligible for CGM. Some of those people didn't have endocrinologists. In fact, by early 2027, we anticipate that insurers will start covering CGM for all patients with diabetes, regardless of insulin status. That would mean that over 40 million Americans, or 13% of the United States, would all of a sudden be eligible for CGM. This gives us at MGB a really narrow window to prepare primary care for what is going to be a flood of patients asking about CGM and wanting to use CGM.
So we developed a one-year toolkit for the implementation of CGM in primary care. Our toolkit has three main components. For the first component, we support the development of operational infrastructure within each primary care clinic. This includes providing workflows, protocols, Epic smart phrases, and even quarterly key performance indicators to support clinics as they implement CGM. The second part of our toolkit is standardized education and training. For example, we host a device wear and share at all of our clinics so that providers and staff get a chance to try out a CGM and learn both the pearls and the pitfalls of being a patient using a device. We also provide training to front desk staff to download that CGM data and share it with providers for review with their patients. And we provide education to providers about how to interpret, counsel, and bill for CGM. The third piece of our toolkit is really around supporting the development of the digital health infrastructure at each primary care clinic. So this involves creating clinic accounts that allow the clinic to access patient data. It also involves providing a technology troubleshooting guide so that our medically minded staff have easy answers to patient questions. And finally, we also provide a nursing outreach protocol so that nurses can call patients directly to start CGM from a phone call without needing to bring them in for an in-person appointment, thereby reducing another barrier to access of this important tool.
We currently have completed the rollout of our toolkit at 2 clinical sites and are currently supporting an additional 2 clinical sites at MGH. When we looked at the work that we've done over the past couple of years, what we saw was increased and sustained CGM use in primary care. At my clinic site, Revere Broadway, we saw that CGM prescriptions starting in primary care increased by 76% over this time period. Of patients who started using CGM from one of the nurse outreach calls that Kristen just mentioned, 55% of them were still using CGM 9 months later. We've also implemented and gone live with clinic portals for each of our clinical sites and started actively enrolling patients in these portals. This means that they can now share their glycemic data in real time with their doctors, and that can be used to help their clinical goals.
But now that we've been live at 4 clinics, we took a step back and we looked at how Lynn's clinic is doing because they were the initial pilot. We looked at their billing practices over the past year. That was the final step for implementation of CGM in primary care. Over the past year, we've seen that both the number of providers billing for CGM interpretation and the number of encounters in which CGM interpretation was billed for has multiplied exponentially, creating a new source of revenue for the clinic, which could be used to support ongoing CGM implementation. But we didn't just build a toolkit. We've also created a community of experts networked across clinical disciplines and across clinical sites. This will help ensure sustainability of our program as we onboard new clinical sites and provide a resource of community experts who can help new sites come on board. For example, we've created a partnership with the MGB Digital Access Coordinators to develop a referral program so that the digital access coordinators can address some of the technical aspects of starting up CGM, leaving clinics to really focus in on the medical benefits. Along a similar vein, we've partnered with pharmacists situated in these primary care clinics to ensure that the infrastructure that we're building supports everybody in achieving success in managing their patients.
So what's next? We have the toolkit and the supportive clinical community that's learned the pearls and pitfalls of implementing CGM in primary care. What we need next is support from clinical leadership and internal budget decision makers. We estimate that rolling out this toolkit over 1 year requires a one-time cost of about $25,000 per clinic. As Kristen said, this cost can likely be recuperated in billing for CGM data interpretation. We also really need buy-in from MGB Digital to directly integrate the data that the CGMs collect into Epic. Right now, that data lives in portals online, and in order to use that data clinically, it has to be manually imported by clinic staff into Epic. This takes a lot of time and manpower. The major CGM vendors both support direct integration to Epic, and we very much implore MGB to invest in this digital infrastructure, especially as more patients start using CGM in the future. We're going to continue to partner with our industry partners to schedule device trainings, buy samples for patients who are curious about CGM, and develop the standards of care for developing CGM in primary care. And then lastly, we would be remiss not to mention our patients. We've brought CGM to a population of people that otherwise wouldn't have had access to this technology. And we want to continue to work with them as we co-design the future of CGM in primary care. We just want to give a brief shout out to all the people who've helped us along the way. It's really taken a village, and honestly, probably doesn't even have half of the people on the slides, but especially to Springboard Studio, who's been incredibly supportive, and we couldn't have done this work without them. Thanks, that's it.
Thank you so much. Next up, we have Tina Onwell and Yasi Zarvapian, who are working across MGB institutions. Yasi at Mass General Hospital, Tina at Wentworth Douglas, and they're here to speak about their solution, Bridging the Gap Pelvic Health Hub Education Library.
Hi, everyone. I'm Christina Anwell. I'm a pelvic floor physical therapist at Wentworth Douglas Hospital.
I'm Yasi Zarbafian. I'm a pelvic and ortho PT at Mass General Hospital.
Today, we're going to be sharing our project, Bridging the Gap, a shared pelvic health education resource library. And in the next few minutes, we'll walk you through 4 things: the problem, the solution we've built, what we've accomplished so far, and what we still need to scale this across MGB. Pelvic floor disorders are common. This includes pelvic pain, bladder and bowel conditions, cancer recovery, and many other conditions that can significantly impact your daily life. 1 in 4 people will experience a pelvic floor dysfunction in their lifetime. That means at least 25% of this room are or will be impacted by a pelvic floor condition. 25% of the population, men and women, need pelvic floor care, but there are fewer than 3,000 certified pelvic floor physical therapists in the entire United States. This gap is huge, and that's why this project matters. This project didn't start as a big initiative. It started with me trying to help my next patient. Day after day, I found myself creating pelvic health education materials from scratch, not because I wanted to, but because there were no usable resources I could rely on at work. I was spending hours each week, often unpaid, building education that should already exist. Question: why does a patient's care depend so heavily on which provider they happen to see, or what educational materials they are given? Pelvic healthcare shouldn't depend on chance. It should be consistent, evidence-based, and accessible by design. To understand why standardizing education matters so much, we need to look at the gap between need and access in our current system. At Wentworth Douglas Hospital alone, pelvic health PT referrals have increased 148% since 2021, with another 150% increase expected by 2030. The need for pelvic health care is exploding, but the workforce simply can't keep up. Providers and patients feel this gap every day. Patients are waiting 6 to 12 months just to be seen for pelvic floor physical therapy. Think about what this means, 6 to 12 months before any symptom relief, when many patients could be doing something to help themselves much sooner. This waiting period is a missed opportunity, and with the right educational materials, patients could reduce symptoms, prevent decline, and we could relieve pressure on an already overwhelmed system. Because when this system breaks down, patients are going to be the ones that pay the price. To show this in real time, we wanted to walk you through a real patient's journey navigating pelvic health care in the current MGB system. This patient was treated for cervical cancer both at Wentworth Douglas and the Mass General Cancer Center and developed pelvic floor dysfunction. This is very common in cancer survivors due to the use of radiation therapy. Over 8 months, she saw 3 different providers for the same symptoms, and at each visit, she received different and sometimes contradictory education on how to fix her symptoms. None of the instructions given helped her symptoms. She eventually reached pelvic floor physical therapy and received clear guidance and the correct educational materials for her condition, and her symptoms improved significantly within just 2 visits. In this case, no one did anything wrong, but the system failed to provide the right education materials at visit 1. And this is because there are no standardized shared pelvic health resources across our system. What should this system look like instead? In an optimal model, at visit 1, pelvic floor screening takes place, and if needed, pelvic floor PT referrals can be initiated immediately. During this visit, providers, regardless of specialty, will be able to give the patient standardized pelvic health resources. When patients leave this first visit, they'll have education and resources to begin addressing their symptoms immediately and not months later. But for this to work across disciplines and across sites, all clinicians will need access to the same resources and the same tools. That's where this project comes in. I began this work at Wentworth Douglas Hospital with my own patients and with some of the providers I work with. And along the way, I met Yasi, and together we began building this project across sites.
Exactly. I met Christina and I realized I was doing the same thing. I was a newer clinician. I was trying to create all these educational material for my patients when providers were asking me to give them something while their patients were waiting 6 months to be able to see me. And we were all asking the same question, why does this material not exist within MGB that we can access, or anywhere else for that matter? This led us to create the MGB Pelvic Health Patient Education Resource Library, a digital library of standardized evidence-based pelvic health educational tools. And this isn't just a collection of PDFs, it's an infrastructure for providers to use. So here's an example of what already exists in the system. There are multiple variations of this handout and inconsistent information with minimal visual cues. This is trying to explain to someone how to do a pelvic floor contraction, and it's just someone laying down. So it's not very helpful for patients. And we know access is not the only issue with pelvic health. We know it comes with a lot of stigma and embarrassment and confusion, and it can dramatically affect patients' quality of life and their participation in society. Many patients struggle to visualize their pelvic floor, understand their symptoms, and know how to engage their pelvic floor muscles. And we know visual resources can help with that. So here is some of the material we have created so far, with support from with great support from Springboard Studio every step of the way, and MGB Workfront design team, and multidisciplinary input across MGB from all of our colleagues in different disciplines. We were able to create these clear visuals and handouts to be used across disciplines at visit 1 when symptoms are screened. We also designed internal referral navigation tools for clinicians and operational infrastructure for them to use. This will allow our patients to engage in their own care with evidence-based tools, even while they're waiting for specialty services like pelvic floor PT or urogynecology. And as Tina mentioned, there's only 3,000 of us in the whole United States. It's impossible for us to serve everyone. So we know that, and this is another version. we know the impact is clear. When education is provided early, it will improve patient experience and quality of life. It will decrease number of visits the patients need for their symptom management, and it will improve wait times while protecting specialty capacity. It will provide efficient, sustainable access within our own hospital system. And hopefully beyond that, we have big dreams for pelvic health. This isn't just better care, it's smarter care and more effective care. So we have received overwhelmingly positive feedback from our colleagues across MGB, from different specialty providers to our patients and pelvic PTs. Clinicians have told us they didn't even realize there were pelvic floor resources that could exist, that could help, and where to access them. Patients have told us they wish they got this information 3 months earlier while they were waiting to see pelvic PT, so they could have managed some of their symptoms before they came to see us. This is the gap we're trying to fill. So what we need to advance this work is digital and epic support to optimize the workflow, clinical leadership champions across disciplines like primary care, rehab, to implement this, and sustainability funding for updates and transition to multiple languages to provide access to the diverse community of patients we serve. We're so lucky at MGB that we serve patients from all over the world and from all different backgrounds, and we can have such a huge impact if we can have these resources available. Pelvic healthcare shouldn't depend on which provider you see or how much time your clinician has to create the material that Tina is providing. It should be consistent, evidence-based, and accessible by design. As mentioned earlier, 1 in 4 people have a pelvic health condition. We know we need more access for it. With your help, we hope to bring pelvic health education to every patient and every touch point across MGB. Thank you.
All right. Up next, we have this Comfort Cart Care Initiative, enhancing safety and well-being of our aging patients, excuse me, parents too, I guess. What's on my mind? Unfortunately, Miranda Lavelle was not able to join us here today, so I'm going to say a few brief words about the work she's been doing on this initiative. So Miranda has been an emergency room nurse at Cooley Dickinson and has witnessed firsthand the challenge of boarders in the emergency department. And boarders are folks that have been seen and need to be admitted but are awaiting that inpatient bed. They could be in rooms, often they're in hallways because emergency departments are just incredibly overcrowded. And her project aims to address the high risk of delirium in geriatric boarders due to lack of targeted comfort measures and insufficient nurse education on early identification of delirium. So to address this challenge, Miranda has been implementing a comfort cart stocked with sensory and soothing tools, along with comprehensive delirium education for nurses. The project seeks to reduce delirium incidents and improve patient outcomes through timely humanized interventions, which is a really worthwhile project, and we look forward to hearing how it continues. So up next, let me welcome Dr. Harriet Kiwanuka, speaking to her work on the development of a novel oximetry device to improve measurement of oxygen saturation in patients of color.
Hello, my name is Harriet Kiwanuka. I am a 5th-year resident within the Harvard Mass General Brigham Plastic Surgery Residency. I'm very passionate about the development of medical devices rooted in health equity and just care. Today, I will be sharing my journey over the past year as I began my development of a novel skin tone agnostic oximeter device. Thank you so much for this opportunity. First, let's talk about a serious problem at hand. Right now, today, we cannot accurately measure oxygen saturation in Black and brown patients, and our patients, my patients, are suffering. So why does this basic problem exist? It's because our current technologies were not built for darker skin. Current pulse and tissue oximeter devices use absorbance spectroscopy technology, where specific light frequencies are shown through skin and absorbed through a back-end sensor. This transmitted light is absorbed by red blood cells. The differential absorption by red blood cells allows us to tell how much oxygenation is in different tissues in blood. The intrinsic flaw of this technology is something that I call melanin interference. So when this light is shown on a patient of color, the melanin that they have also absorbs the light, so it leads to inaccurate readings of their oxygenation status. Seems like a huge problem, right? Well, it is. What is shocking is that we really didn't realize how big of a problem this was until the COVID-19 pandemic, where the disparity became quite obvious. In the New England Journal of Medicine, a group showed that in one study where there was 10,000 patients in the ICU, over 3% of the patients who are Black were 3 times as likely to have pulse oximetry readings that did not correspond to their true oxygen level. Current day pulse oximeters hit dangerous low levels of oxygen in these patients in comparison to their white counterparts. On a grand scale, it is truly a problem of life and death. The basic device that is almost ubiquitous within healthcare spaces, in every hospital and clinic setting, is inaccurate for patients who have darker skin. And that's just not right. This problem shows up every day in my clinical practice as a plastic and reconstructive surgery resident. I'll share a personal anecdote with you from my first year of residency. There was a young woman who came in after a catastrophic car accident. She had a horrible lower extremity fracture. After orthopedic surgery fixed her bone break, we as plastic surgeons performed the reconstructive surgery that allowed for coverage of that wound. Initially, she was performing well after the surgery, but then suddenly on postoperative day 5, something just wasn't right. We took her back to the operating room and she just did not have blood flow to the flap. And we could not tell as providers that there was something wrong. I can't help but wonder with this patient's story, if her skin was not as dark as mine, would she have had a different outcome? As you see depicted here, typical clinical observations, when you look at reconstructive flaps, you have a purpling and or bluish hue of the flap when there's a trouble sign, when blood flow isn't going quite white to the flap. For patients of color, as you see here, when there's a dead flap, it really looks pretty similar. So in reconstructive surgery, when you have that first 2-day window of salvaging a flap, we miss that in Black patients. Let's now talk about the stakeholders of this device. So the decision makers of a new device such as this are the healthcare administrators. So these are the people that essentially tell us which devices we use in the hospital. End users are providers who care for diverse patient population. They will ultimately be more confident in their ability to identify, diagnose, and escalate care for patients who have more accurate tissue and pulse oximetry devices. However, when I think about this project as a passion project of mine, most important, the beneficiaries include patients of color. From the Tuskegee experiment to Henrietta Lacks, medicine has an ominous history of the exploitation and experimentation of Black and Brown patients. And we see continued in 2020 and beyond how there are differential outcomes for patients of color. Now, as I identify this problem, this is one way that we'll be able to deliver more just care. So, a very junior plastic surgery resident had identified a problem. I was seeing multiple patient outcomes in my training, not just from that anecdote that I shared earlier, that we just didn't have the adequate technology to diagnose and escalate the care. And it was a huge problem. The FDA actually released a statement in January 2025, which is a few years after I saw this issue, that we needed to come up with a more sensitive device, a pulse oximetry device, in order to improve patient outcomes. Because ultimately, making a sensitive oximeter device is beneficial for all patients. This is a concept that I hold very true in everything I do in my care of patients. When you identify a problem for those in the most marginalized communities, often the solution improves healthcare for all. I was so fortunate to have funding from the Design Impact Awards. It was my first time pitching a problem and idea as an innovator. This journey would not have started without the great mentorship from faculty within the Division of Plastic Surgery. I remember one day, as a very junior plastic surgery resident, I went to Dr. Orville and told him that what I'd been seeing in the hospital and how I wanted to try to develop something during surgical residency, and he supported me wholeheartedly. Following this, my team components were very important. I needed to complement my clinical knowledge on the issue with those with technical expertise. I collaborated with Dr. Srivastavan, an assistant professor in engineering, to assist me with design and development. The Evans Group of the Wellman Center for Photomedicine at MIT was a great collaborator for optical engineering expertise. And we secured our worker bees through enlisting Harvard undergraduate and graduate students to work on development of the idea. At this time, I am not at the liberty to share the details of my prototype and the solution to prevent public disclosure of intellectual property. The process of securing a patent is ongoing, and I want to make sure that this solution is able to be delivered to patients. However, I wanted to talk you through very broadly what we thought about when developing this solution. After 2020, when this landmark New England Journal of Medicine paper came out, a lot of different groups started to think about this problem, which I think is an amazing thing. I love the fact that a lot of people have identified this and are working on a solution. However, when I was approaching this problem, especially with my background in basic translational and clinical research, I knew that leveraging technology that already existed is one way that you're able to take things from bench to bedside quickly. And also, I want to make sure that when I was making an equitable device, that it would be available to everyone. So I wanted to make sure it was cost effective. So leveraging the technology that already existed while also kind of changing it a little bit incrementally and seeing the gains was our approach. And we've been successful. Over the past year, we were able to develop a functioning prototype. We performed phantom testing with dyed silicone to mirror different melanin concentrations. We found that in comparison to the market O2 sensor, our sensor has less light attenuation or less melanin interference. Important portions of this graph are eliminated to prevent public disclosure. However, it depicts that as we went on in the journey of this past year, initially the light attenuation was quite high, showed by the red bar, but with our iterations of the device, it's gone down to next to none. Here, I've shared some lessons learned from a novice innovator. I had a timeline of the speed in which I wanted to develop this prototype. This time last year, I thought that I would be in humans, testing this on animals, ready to show this to everyone. However, I know that I still have a long time to go. But that is not a failure. I've shown now that I shouldn't be disillusioned that I'm going slower. It's just a slower pace to complete the marathon. Also, motivation of the team members was no small task. My timeline was not their timeline. And when there were setbacks and failures, I need to remind them that these are things that we can learn from and go another day trying to improve upon our device. And ultimately, there is no replacement for experience. With all the setbacks of this past year, I was allowed to read more. I don't have an engineering background, so I was very cautious that I would have certain limitations, especially when things didn't work out well. But every single failure that we had allowed us to improve upon the device, which I'm very grateful for. The next step at this time is trialing the prototype in human and animal subjects. This in itself will take a lot of paperwork and patience, but I am motivated to have this device used within the clinical space for better outcomes. Ultimately, my ask today is for continued support on the journey of transitioning this device from bench to bedside. I feel so fortunate for this opportunity to present in front of all of you today, and would be honored to leverage your expertise to help with efficient human trial testing and production of the device on a grand scale. With that, I just want to say thank you so much to the Springboard Studio team for all of your patience and support over the past year. It's not a small task supporting a fifth-year plastic surgery resident who's running the services at Mass General and Brigham Women's Hospital. I want to thank Dr. Orgel, who's sitting in the audience, for always believing in me and sponsoring me in all of my big ideas. And thank you so much to my husband, who's also in the audience, who's very patient in all of the after hours work that I was doing on the weekends with our 2-year-old daughter. Thank you.
All right, thank you. We're going to change pace here just a little bit. As we've mentioned, Demo Day wraps up the formal support provided by our Springboard Studio team, but it is also the first day of the next chapter for teams continuing on with their ideas. And to that end, we wanted to spotlight some of our alumni. Our She Solves Awards cohort, we held their demo day right here in 2024. And so as we prepared for this demo day, we wanted to go back and ask them, where are you now, a year and a half later? So of those 7 teams, we interviewed 3. So this is just a sampling of that cohort. But we wanted to showcase where are they now. So we'll do just a quick video. It's less than 4 minutes to hear about their experience.
A year and a half after receiving funding and support through the She Sells Awards program at the Springboard Studio, we set out to answer a simple question. Where are they now? We reconnected with a few of the alumni teams to see how they've continued to refine and evolve their projects. We heard firsthand how their ideas have grown, the impact they're making, and where their journeys have taken them since their demo day graduation.
Our company is called Life Medical. It was really born out of our own experience as general surgery residents. We are currently in the process of working on our first prototype, which is a integrated scrub cap with a lamp. A lot of the tools that we used in the operating room were designed when there were very few women surgeons.
Thanks to the Stepping Strong funding that we received, as well as the Springboard Studio She Solves grant program, we were able to plan this very complicated interdisciplinary program that has community health workers, patient navigator, it has OT, it has strong referrals to PT and physiatry.
We work with patients with hearing loss, and we were finding that there were gaps in our care where even something as simple as grabbing somebody from the waiting room can be a big challenge. Our project was all about improving accessibility within the audiology department and further expanding that to other departments.
You know, I get excited every time I see it because it really does look like this product that we were envisioning. And we are working right now on transitioning from a looks like prototype to really taking it the final step to being an actual product.
We were able to show enough excitement and promise that the Stepping Strong Foundation has continued to fund the Trail Clinic perpetuity and potentially scaling it across Mass General Brigham as well.
At Demo Day last year, we got to present our initial go of having the features within our department. So now when you check in, you get a feature. I can think of a handful of patients that they've always felt like they needed to rely on their partners that are with them to be listening for their name. And instead, they have this little disc in their hand, and that's all they need to be able to know that, like, no, it's my turn, and not needing to rely on just another communication partner.
The kind of path forward, which to 3 people that have otherwise no experience innovating can be really nebulous. Having a group that's there to guide us through the initial, really, I think, completely open-ended beginning phases was so helpful.
There are a lot of grant and funding opportunities out there that are very arduous and burdensome, but that's in some ways not this. This is like designed to be internal. It's supposed to support our employees, and that in itself is valuable, I think.
It's nice to connect with people even when it's not related to your projects too. It gets you out of your silo. Yep. It's really easy to leave the demo day super excited, and then within a week, oh my goodness, this happened in the clinic and this happened in the clinic, and it's so easy for those goals and aspirations to get sidetracked. And so I would say even the day after demo day, sit down and say, this is our 3-month goal, this is our 6-month goal, this is our 1-year goal that we will work.
You know, you build this like idea and it encompasses the mark, but now it's kind of tuning it down to really make it efficient, make it work, make it what's best for patients.
I think one innovation spurs another and another and another.
We would not have gone forward with this project probably if we had not won this grant. Like, it was just at the perfect time. It was the impetus that we needed to say, there's someone out there that believes in our idea and believes that we should pursue this. If not us, then who's going to take on these challenges?
Interested in supporting frontline providers and staff who are making healthcare more user-friendly? Let's chat.
I hope one of the big takeaways from that video is that these early stage ideas don't stay early stage forever. They keep going, they keep refining and iterating and progressing. And so to the cohort here, I hope that's inspiration of, it feels like you have a long journey ahead of you. Keep going. I can tell you 1.5 years flew by since they were all sitting here. And I think Dr. Brittany Powell at the end there really nailed it by saying, who, if not us, should be solving these challenges? And that paired with the flexible funding that philanthropy provides is really the catalyst for solving challenges that we're facing in the front lines. So on to our next. We have a video as well. Is it first? Okay, we'll set up the video situation again. We have Tessa Goldsmith and Dr. Sophia Shalhoot from Mass Eye and Ear speaking to artificial intelligence powered survivorship care plans for patients with head and neck cancer.
No, not you. Hello, everybody. I'm Tessa Goldsmith, Sophia Shalhoot, my partner in crime. And we're here today to share our project, which is curating AI-generated survivorship care plans for patients with head and neck cancer to inform their journey after their treatment is completed. A bit of background, I'm a speech language pathologist by training, and I've had a very long career, as you can see, working with patients with head and neck cancer at Mass General and Mass Eye and Ear. And I've been up close and personal with my patients, in addition to their speech and swallowing problems, with all the other problems that they faced after treatment was completed. Beyond the speech and swallowing, they had nutritional issues, posture, dentition, fear of recurrence, how do they go back to work? And all of that had to be part of our conversation. They were not routinely addressed by other members of the team. So as far as head and neck cancer is concerned, it affects the structures of the face, the mouth, the throat, the voice box, and the sinuses. It's the 7th most common cancer, and about 65,000 new cases are diagnosed every year in the US. We treat about 1,500 cases every year at Mass General, Mass Eye and Ear, and when you add MGB wide, it's even more, a greater number. And fortunately, head and neck cancers are treatable, and many patients are alive many years later. The trouble is that the treatment for head and neck cancer, which includes surgery, radiation, and chemotherapy, depending on the kind of cancer, is arduous and grueling and long. And the side effects don't often go away when the patient's treatment is finished. And sometimes the symptoms resolve only to come back many years later. Head and Neck Australia. Head and Neck Australia created a very powerful video which shows more effectively than I can describe what a percentage of our patients, not all, face. Some of this may be hard for you to watch, but it's only 40 seconds.
Head and neck cancer is unlike any other cancer.
It is a cancer that you actually see in the mirror. You see it in the face of the person sitting next to you.
Head and neck cancer affects the mouth,
Jaw,
and teeth,
nose,
tongue,
cheek,
muscle,
throat, skin.
ear.
The treatment can be brutal.
It affects limbs that people have the cancer.
swallowing, eating and drinking, even breathing. Let me help you. There's a massive negative impact on your sex life.
And your mental health.
A cancer team congratulates us when treatment is finished.
They tell us we're human, and we're grateful.
But the journey to our new normal is just beginning. I found head and neck cancer is different.
So as you can see from this very busy slide, patients experience a range of side effects in the acute, subacute, and long-term scenarios. Some of these resolve, some get better, others, new ones pop up. Not all patients suffer from these issues, but more than 60% of patients complain of something wrong. The bottom line is that our patients are surviving, but not all of them are thriving, and there's no comprehensive service to manage these side effects. It's this issue of thriving that took me out of retirement and back into work with this population. So a lot of our patients are basically lost in transition. They're navigating life beyond treatment. They don't know where to turn, what's coming next. There's lots of people that they've met in their treatment journey, and they don't know when the next scan is. They don't know what side effects are coming up, what they should do about them. And so I had an idea before last year that I wanted to do something about thriving in this population. And I realized that I needed a partner to help me to figure out how to make patients at the center of their care. I knew that the solution to an effective post-treatment cancer course was having the patient have the knowledge, the patient and their care partners. So survivorship care plans have been touted by many organizations as a way of empowering patients to know what to do. The trouble is that to create a survivorship care plan for a patient takes a very long time. You've got to go through the medical record and find all the information, and it's very difficult. And I originally applied, I was talking to Chris about this, and maybe applied for the Design Impact Award to see if they could help me figure it out. But I luckily was introduced to this amazing person serendipitously, and Sophia just jumped on the idea. Sophia is an assistant professor in otolaryngology at Mass General and the director of computational and AI services at Mass General, and we found a match made in heaven. So Sophia totally understood what I was saying. She's jumped into this project, and we've started on our journey.
So let me be clear, this isn't one of those instances where AI is taking a job a human was doing. In fact, no human was actually doing this for us. So despite NCCN guidelines, Commission on Cancer guidelines, that every single cancer patient should go home with a survivorship care plan, even at a premier institution like MGB, we just weren't doing it. And for good reason. It's very labor intensive. It requires someone sitting between 45 minutes to 85 minutes, depending on the complexity of the journey, to sit down and go through an entire patient's journey of medical records to curate a personalized plan. No one was doing it. And so our goal was to get AI to do it for us. We wanted to have an AI automated process that can do this in seconds for every single patient. The goal here is that it would lower the workload, be less error prone, and hopefully improve patient outcomes. So how we do this is we have several sources: the electronic health records, nurses' notes, speech pathologist notes, imaging, pathology, and we wrote in-house code using natural language processing under the hood. So for those of you who aren't familiar, NLP is basically just getting machines or computers to understand human written form. Actually, a very good example is the unwanted transcription that just happened. That's a very real world use case of NLP. So we wrote in-house code to basically go through every single patient's chart and help us curate a structured patient SCP. And so with this, it assembles everything the way we want. So everybody's form looks similar, but then it's also very personalized. And the final output is a treatment summary, health promotion, resources and support, as well as a personalized risk score. So I'll talk about that next. The personalized risk score was developed by using over 15,000 patient records of head and neck cancer patients who've come through our system since 1975. And we trained a deep neural network to determine exactly when these patients are likely to have adverse events or some of the side effects or some of the issues you saw in the video at the beginning that Tessa showed, and to actually give a risk score that's accompanied by the survivorship care plan to discuss in the survivorship clinic. And so when we started here, we had a implementation plan that started with obviously the AI model development, which we completed. Phase 2, which is where we currently are now, involves a pilot test. So during phase 2 right now, we have an IRB approved protocol where we're getting these AI generated SCPs in front of patients who consent to the research protocol. And we're trying to get feedback from them using mixed methods. So this includes qualitative and quantitative studies to see what exactly they like or don't like about the SCP, what else they want to see. And so now we're in the iterative process of improving these SCPs to make sure they're exactly what patients want. Because the whole point is that the patients refer to these all the time and with their caregivers and with their managing clinical team. We don't want it sitting in a drawer somewhere that they never really touch again. So here is an example of the current SCP we have. So I'll just go through this briefly. This is generated by AI, a couple pages long. The first page gives the patient's information as well as information about their caregiver, and then their entire managing team. Who do they talk to if they have swallowing issues, speech issues? They need to see their medical oncologist again, etc. The next part is their journey from day one, the diagnosis, the pathology, as well as a treatment summary. What surgeries did they have and where, and what effects happened after that? Were they admitted to the hospital afterwards? So it kind of goes through their entire patient journey and reminds them. Again, feedback we've gotten so far, sometimes this is a little dense. So we're working with the patients now to see what is actually usable for them. And then we give the risk score, as well as follow-up care plan and surveillance. And finally, we offer healthy lifestyle interventions to help them with their thriving phase after the treatment, as well as resources and support groups.
So what are our next steps? We have to complete this pilot and make sure that the survivorship care plans that we've developed are useful to patients of all walks of life. We have to analyze and refine them and make improvements so that patients can really use it. We also have to plan for implementation, which means that an automatic survivorship care plan gets deposited into the patient's medical record, which is easier said than done. Ultimately, we will evaluate the survivorship care plans on each of our stakeholders. The patient know more about what happened to them and what to look out for in the future. The doctor's visits will be more streamlined and more specific, and they will be able to answer the questions appropriately for the patients. We will also be able to see whether early intervention on particular areas of deficits that patients have will improve emergency room visits. Do you wait for the pneumonia, because you've been aspirating when you're swallowing? If you can catch that a little bit sooner, there may be some long-term impacts on the healthcare system in general and the institution at large. So I think that's it. Thank you.
All right, next up, Dr. Molly Warren, Kristen Sullivan, and you're seeing Sophia Shalhoot hang out up here, and they will explain that. Speaking to their solution called DAISY, which is an AI-guided insurance and care navigation for NICU families and hospitals.
Hi, everyone. Thank you so much for coming today. My name is Molly Warren. I'm a pediatrician and the director of the Transition to Home program. I'm joined by Kristen Sullivan, who is the MGB program manager for MGB Virtual Care, and also Dr. Sophia Shahut, which I already heard about, but is the director of computational and AI services for all of MGB. Kristen and I have actually been working together for several years. We started about 5 years ago to develop the Transition to Home program. And through our work, we saw patterns of the same insurance and access barriers to care come up for our families again and again. And for a long time, we were really trying to solve these problems ourselves and trying to piece together answers the best that we could. And then eventually we thought, I wonder if AI could help us with these issues in a more clear, fast, and consistent way. So we brought the idea to Springboard Studios. And after that, we were able to connect with Sophia, who brought the technical experience that we needed. And together we combined the clinical experience, insurance and operations knowledge, and AI expertise to solve this very complex problem. First, I want to start with a story from one of our NICU families in our system. Nick and Jenna were expecting their first child and everything was going really well and as planned. But then at a routine prenatal appointment, they were told that their baby was in distress and would need to be delivered right away. Their son was then born at just 25 weeks, weighing barely over a pound. And in an instant, they were thrown into the world of the NICU, facing fear, uncertainty, and the daily question that every NICU parent wonders, is my baby going to be okay? But very quickly, another crisis began. They began receiving hospital bills, totaling tens of thousands of dollars. And at first they thought this has to be a simple mistake. You know, they knew that their insurance was contracted with the hospital, so they really thought one quick phone call would really clear all of this up. Instead, it became endless hours on the phone, repeated transfers, conflicting answers from the insurance company, and no clear resolution. Most shockingly with all of this is Nick actually works in health insurance himself, so he knows the language. He knew who to call, he knew the system, and even that he couldn't fix the issue. So while their baby was critically ill, Nick and Jenna were pulled from their baby's bedside into this administrative chaos. And through the Transition to Home program, we actually realized this is not a one-off or isolated story. We see families as they're nearing discharge, sometimes months after they've been in the NICU, with coverage issues still unresolved. And these administrative issues can often affect care, leading to delayed discharges, canceled primary care doctor appointments, and referrals to outpatient providers that aren't in network, and issues of home medical equipment and home medications. So it's really not about just bills. It's about whether a medically fragile baby can go home safely and still stay connected to the care that they need. And Kristen was seeing the same pattern with this on the system side.
So over the course of my work with Molly, we would work together essentially every week, fixing insurance issues, registration issues, and coordinating things on the back end that really should have been handled on the front end. And additionally, I was seeing these same babies show up over and over again in another place in our finance meetings and on denied and rejected claim lists. And what we really uncovered in our work together is that NICU coverage isn't just complicated, it's uniquely fragile. And given that we have a room full of people that work in healthcare, I would ask the question, could you think of any instance in healthcare where a patient enters our system without a name, without a primary care doctor, without their own insurance information, and you can guarantee that during the course of their stay, their insurance is going to change? Because that's what happens for every single NICU baby that comes in. And additionally, I'll just call out that these stays are incredibly expensive. And because of these long, expensive, complex stays, one misstep really snowballs and results in coverage gaps, identity mismatches, authorization barriers, and delays. And what's unique about this problem is that many teams touch the problem, case management, providers, registration, billing, but no one really owns this whole pathway, and families really end up being the ones that bear the burden of those gaps. And the result is a perfect storm: delayed discharges, gaps in care, family distress, and preventable denials. And so at this time, we asked ourselves, what would it look like to meaningfully improve this system? And when we really set out to do this work, we realized that the solution for this couldn't live in one department. It wasn't a registration issue. It wasn't just a billing issue. It wasn't case management alone. And so we really built Daisy with the understanding that it had to sit at the intersection of coverage, care, and coordination. And we built an AI-guided navigation platform that gives families a clear roadmap and also gives hospitals earlier visibility into what's stuck. And that really matters because NICU care is life-saving, but it's also financially fragile. It's a high-cost, high-fixed resource where coverage errors, self-pay days, and denials can really quickly compound. And so for a real solution, we knew that we had to add value in 4 different ways. We had to figure out a way to protect revenue by catching enrollment issues and preventing denials before they happened. Improve throughput by making coverage, authorizations, and equipment readiness visible earlier. Retain patients by keeping high-risk infants connected to MGB specialists and instead of falling through the cracks. And then advance value-based care initiatives by improving continuity and reducing avoidable returns. Based on very conservative estimates, we estimate that a software like Daisy could unlock roughly $2 to $3 million a year in annual health system value throughout our network. And we wanted to understand really what would that look like for the family as well. So today, when a NICU family encounters a coverage issue, if caught at all prior to discharge, the response is reactive. Someone calls a payer, a provider's on the phone checking eligibility, and a family waits. And Daisy replaces that with a closed loop system. It connects coverage status, care milestones, and coordination steps into one roadmap. And so for families, that feels like clear steps, coverage updates, and fewer surprises. And for hospitals, that really means earlier risk flags, less rework, and fewer preventable denials. The key difference really is the closed loop system. It's not just giving information, but tracking whether or not the next step actually happened, and then escalating it when it doesn't. And so Sophia was able to take this concept that we had and actually build something that we could scale and test.
We're excited to share with you Daisy's First Bloom, our app prototype. It's compatible on Apple and Android devices as well as in your browser. Essentially, it starts off by trying to really understand the family's personal journey. So it extracts information directly from the EHR, but also asks the patients to input some upfront data. And then the goal is that it actually generates a personalized roadmap for what they're supposed to do right after discharge. So the goal here is to make sure they never miss a follow-up appointment, which happens often. They understand any authorizations they need, and they're actually adhering to the discharge plan, which in this journey I found out very detailed and can be very complex. Like baby formulas come in many different shapes and sizes, and I didn't realize that new parents sometimes even get this wrong. So our goal is to not only alleviate the navigation process for the families afterwards, but also to help the hospitals and the providers get ahead of any of these missteps. And so for our next steps, we want patient feedback. We want to hear from the families. Are our forms too long to fill out? What else do they want to see? So next step is to run an IRB approved protocol where under a research arm, we see what they want, we get them to use it. And then after we have the second version of our app, we're going to go for full EHR integration and then try and actually assess Daisy's impact. So to do that, we'll be measuring success across 3 different sectors: clinical, operational, and financial. So from the clinical side, we want to look at readmissions after discharge. From operational impacts, we care about discharge delays and rework burden. And from the financial impact, we care about denials and delays and self-pay days. And so with that, we're trying to show that Daisy is not just a family support tool, that it can also impact hospital operations as well as finances.
So bringing it back to Nick and Jenna from the beginning, when we actually last spoke to Nick, which was about 2 months ago, they were celebrating the 1-year anniversary of their baby being discharged home from the NICU, which is really wonderful. And he shared with us that they still had bills and issues that were unresolved from their NICU stay a year ago. So we know that we can't remove the medical complexity of a NICU discharge, but what we can remove is the avoidable administrative complexity that stands between families and the care that they need. And really the time for DAISY is now. We already know that payers are using automation and AI on their end for claims and denials quickly. And, hospitals can't meet this reality with manual cleanup after these automated denials have already gone through. So we really need proactive intelligence on the forefront like DAISY. And when we think about next steps, clinically, DAISY is ready to be piloted through the transition to home program. But to fully implement and evaluate it, we need revenue cycle partners to help us measure denials, self-pay days, and revenue that's at risk. We need operational sponsors to really help connect those workflows from registration, billing, and the clinical teams and case management. And we also need funding and data and implementation support to move this from pilot to scale. And we're talking about NICUs and special care nurseries, but this model has very clear potential for other complex and pediatric and adult medical transitions. In the end, families should not have to fight this complicated insurance landscape on their own, and DAISY is how we start.
Thank you, team. All right, next, last but not least, please welcome Eileen Bean and Stephanie Hardy from Newton Wellesley, speaking to their work on a departure lounge.
Good afternoon. My name is Stephanie Hardy. I am a project manager at Newton Wellesley Hospital, and I am here today with Eileen Bean, my colleague, and we're thrilled to talk to you about our journey over the last year working on the departure lounge. So over the last year, when we applied for this award, we were facing a lot of the same challenges that many hospitals across the country were facing. We were seeing an increase in surgical volume while also experiencing record numbers of ED visits and an increase in inpatient volume. Together, these were causing throughput challenges for us, and we were seeing capacity challenges as well. So we thought about what we could do to address these challenges, and we wanted to leverage a departure lounge. So the departure lounge is a nice, bright space located right by our east lobby where patients who are discharged are able to wait for their rides. We were seeing that historically we had many patients who were discharged at 10 a.m., 11 a.m., and commonly they would say, oh, but my ride can't come until they're out of work. And they would be able to stay in their beds in their rooms until 7 p.m. And so this was a challenge when thinking about that. At the same time, we had orders in the emergency department or our operating rooms potentially being placed on hold because there wasn't a bed available. So we really wanted to find a way for these patients to wait in a space where they could be close to the coffee shop and also at the same time make it easier for their loved ones to pick them up. This location is right by the main entrance to the hospital. Instead of having to pay for parking, their loved one can just pull right up and see the patient waiting and walk in and grab them. So this saves a lot of time for the patients and their families as well. So we put together a task force to really look at the solution and see how we could operationalize it. And our main team consists of our Chief Nursing Officer, Sandy Muse, as well as Eileen Bean. She's one of our nurse directors on one of our medical surgical units, and myself. We also feel so fortunate that we had the very strong support of our senior leadership team throughout this entire process. We would not have made it as far as we did without them. And we also, of course, appreciate the collaboration from Springboard Studios as well as Brigham and Women's Hospital. So now I just want to take you through what our journey has looked like for the past year. So as soon as we found out that we got the award, we were thrilled and started on some background research to figure out how we could get our providers, nursing staff, and everyone else at the hospital on board with the solution. We went across our entire system to see who else might have a departure lounge that was successful, where had some people maybe learned that their departure lounges were not working. And we were so fortunate to come across the Brigham, who has a very strong and thriving departure lounge. And based on everything we learned from the providers and nursing staff, we realized that we really needed to staff the lounge. So originally, when we were thinking about it, we thought, okay, all these patients are going home, they're safe, they're able to ambulate. they can be in the lounge on their own. They're going to be home on their own, but that was one of the biggest barriers that we were seeing. So we began piloting staffing the lounge in October of 2025. And we were able to actually do so with a patient care associate off of Eileen's unit, and that was the departure lounge ambassador. So you'll see Ricardo's picture on the front poster board as you walk in. That immediately skyrocketed our utilization to 5 patients a day, and we were previously having about 5 patients a month, maybe, if we were lucky. So this was a big change for us. We also then started to embed accountability structures into already existing meetings. So our weekly high reliability rounds started to include discussions about the departure lounge utilization and how each unit was doing. We wanted to make sure that there were opportunities for frontline staff to provide feedback as well as leadership so that everyone felt a sense of joint ownership. And this allowed us to get to about 8 patients per day in the lounge. What we are looking at right now is actually experience enhancements. We want the lounge to be something that patients ask to go to. They want to go like an exclusive airport lounge. And so we recently completed an ideation session with Springboard Studios where we thought about how we could delight patients. And so we are actually super excited. We have some upcoming construction plans that will include some of the items that came up in that brainstorming session. And we also had the opportunity to work with Michelle, who is on the Springboard Studios team, to design some new patient-facing handouts and materials. So on the left, we have some new business cards that providers and frontline staff can hand out to patients. And on the right, we have a new menu insert that will go into the inpatient menus. And we're actually very excited because I think that went live today. So we're hoping that patients will now start to ask if they can go to the lounge and get excited about it. And now I'm going to hand it off to Eileen, who will take us through some metrics that we've been collecting to help us analyze the impact of our intervention.
Thank you so much. It's really been a pleasure to work with Stephanie. She's been a great partner, and it's helped us renewed and accelerated this work, having this opportunity from Springboard. So thank you very much. This slide is showing the monthly departure lounge utilization, and the numbers are speaking for themselves. As Stephanie pointed out, October is when we began staffing the lounge, and it was a game changer, as you can see. We really needed the staff to buy into this concept and trust that we were going to take care of their patients and maybe meet some needs down there. So you can see that we just continue to strive for these numbers. Our arrival time in the lounge versus average med-surg discharge time. So we took like patients from units and the departure lounge. So they were getting discharged average time from the unit around 2:40 p.m. and from the departure lounge around 1:05 p.m., which is a savings of an hour, 35 minutes. And we continue to grow this time. However, it doesn't seem like much, but if you're the patient in ED or the patient in the PACU, as we all know, it's important to get them up as soon as we possibly can. The median ED border hours decreased 37% from October to March, which I don't think is a coincidence. When we started staffing the lounge, we pulled a lot of levers across the hospital trying to get this time decreased. So we're hoping that the departure lounge did and continues to help with these times. So we have gotten a lot of feedback. This one was really great. It was a donor, and I can't say enough good things about the care I received from the person who checked me into the ER all the way to the person who wheeled me down to the discharge lounge and got me a cookie and a coffee waiting for my ride. So it was really nice to hear. Next steps and call to action. So our ongoing goals are to increase the utilization across the med-surg units. We have a little bit of a healthy competition going, so that's fun. We want to expand this to GI, day surgery, and hit at least 15 patients a day. What we need to do is continue funding for the Charlie cards. This is a huge patient satisfier for them to get something down there. Continued support for communication tools, as Stephanie had shown you some, but we also are getting some really great feedback and ideas from our staff, which is nice. Continued funding for the Departure Lounge ambassador. Ricardo was mentioned earlier. He is delightful. Patients love him. So we would really like to make this position, a good one for him to stay into. And then support and scaling to other MGB entities. So Stephanie and I were really lucky. We got to go to Brigham and Women when we were trying to renew this project and get some ideas for them. So we had to walk around, got some great ideas, and we were really appreciative of them sharing this. So we are hoping that if there's any other entities out there that want to talk about our experience, we're happy to do so. And we look forward to continue improving this patient experience.
Well, I know I'm the only thing that's in the way. Is that echoing, or is that that's in between you and either getting to your next roles, because we all have additional roles, or hopefully joining the reception, where I think it's really important that the people in this room start creating community and being together. So for those of you that I haven't yet met, my name is Chris Olson. I'm the Vice President of Design Impact at MGB. I have the privilege of leading the Springboard Studio and working with this fantastic team. I'm also a clinician, so I'm one of the core educator faculty at Mass General Hospital, and I'm also in the Department of Pediatrics. And I'll say, even more so from being a patient or having family members as patients, and seeing patients of my own, that all of these problems really resonate. So I only have 7 points, but one is that bringing us back to the beginning, when Sandra Butler, who directs the studio, really reminded us that the best innovations, where it really starts is at the front lines. These aren't abstract ideas. They're real problems experienced by people every single day. And the people you heard from this afternoon are people who are deciding not just to notice them, but to do something about them. And so the second point is really just to acknowledge these 7 teams, not just for what you built, but for what it took to build to get to here, because we know that you're not done, as they've all highlighted the next steps they need to make these really accessible solutions. I know also that you all have full-time roles, full lives, other responsibilities, and yet you still had the courage to step forward. You were able to be curious, to try something new, and maybe most importantly, to be vulnerable. It takes a lot to stand up in front of a room with new ideas and to sort of invite feedback and to risk being wrong. And so with that, it's really obvious that it takes a lot of courage. And I just want to ask all members of the teams to please just stand up again and let us give you a round of applause. I also wanted to harken back to something Sandra had mentioned early on about catalytic funding. And it was so essential to have the Mass Life Challenge, Mass Life Sciences and Shepherd support these teams and help with the philanthropic support that allows us to help move these ideas forward. What you're seeing now is what happens when catalytic funding meets people who are willing to carry that spark forward. And this moment matters because these ideas are real now, but they're not yet sustainable solutions. A fourth point is just about design thinking, or a subset of which is human-centered design that we base a lot of our ways forward with in the Springboard Studio. And what's really interesting is that it's still relatively uncommon in healthcare. But notably, healthcare is perhaps one of the most human fields there is. The truth is, all of us are designing every day, whether we call it that or not. We do it all the time. And what design thinking does is enable us to come up with solutions that are more compelling to the end user, are more likely to be implemented, and show true value on the investment that's brought into them. And so I really want to encourage people to utilize design thinking in all of the challenges they're facing in healthcare and the rest of their lives. I do want to highlight that these innovators need support, both ideas, and they need partners, and they need the people in this room. This room is pretty special. There's a number of senior leaders from MGB in the room, and I really thank you for taking the time and investing the time to come here and hear about these ideas today. There's a lot of colleagues from different entities within MGB that can help encourage you to move forward, that might have suggestions for you. But there's also a number of people in this room that are from industries outside of healthcare itself and healthcare delivery. There's engineers in the room, there's designers, there's entrepreneurs that might be able to help us. And we really think that this is really essential and catalytic. So the reception that we're going to have is really important for all of these people to get together. So I have one task for everyone in the room, is just try to meet one person that you didn't know before coming here and get to know them a little bit, understand their perspectives from a different angle before you leave, even if you have to rush out. Meet someone. I also want to just thank the Springboard Studio team. So this kind of work doesn't just happen. Creating a space for people to think differently and to experiment and to move ideas forward, really it takes intention. And the team I have the privilege of working with every day has just been phenomenal. And can I just ask the people who work with the Springboard Studio team and Lauren Garlick, who has also been helping all of the teams, please stand up. So I'll just close with this. Innovation doesn't end with Demo Day. It's just getting started. I think today showed that the future of healthcare isn't something that we wait for. It's something that we build together in rooms like this with people like you. There are 82,000 employees at MGB, which is just incredible, right? It's the largest private employer in the state. And if you think about that, that's hundreds of thousands of healthcare years of experience that gives insight into challenges. But we need people outside of these walls as well to help bring ideas forward. Springboard will continue to, or will commit to continue to try to listen to those ideas and find better ways to move ideas forward or support people to move forward. So to our awardees, thank you. Thank you for having the courage. And to all of you, thank you for being here and being part of what comes next. Please enjoy the reception.
I really enjoyed your guys' talk. I the same experience as Nick, was it? Yeah, so my NICU baby, she's turning 1 in 3 weeks, so she's only 10. But very similar story. I was basically tested. I mean, I was here, but I want to make sure that. My parents are trying to like figure all that out. They took that long. So I know they got the so we're waiting to hear back after. It ended up being